me permission.
Yes, Emmanuel, please allow multiple screen sharing. I gave you the host. Emmanuel, can Leanne share now?
Yes.
Now I can. Now I
Yes,
can.
yes.
Great. Thank you. So you should be seeing my screen now. Is that right?
Not yet, Leanne, but maybe it's
Not
just me.
yet.
Now we can.
Okay,
We can
great.
see
Probably
it.
just
It's
a bit
on
of
viewer
a bit of
mode.
a. Okay, great. Brilliant.
Do you want,
all right. Let me close this.
do you want to put it on slideshow? We are seeing the edit mode.
Okay. The question is how. Hold on. How about now? Are you seeing presenter?
Yeah,
No,
yet share.
You haven't shared yet.
Okay. On my side, it is looking okay. Hold on. How about now?
I think it's loading.
It's loading.
Okay. Gotcha. All right. Maybe I'll turn off my. No,
Yeah.
I think the camera
Okay.
is. Oh, great. All right. So I guess I'm very happy to take questions along the way. Also very happy to wait until the end. I'm hoping that today's session will be quite an interactive one. And I can't see hands on my side. So Dintle, if there are hands along the way, if you could just stop me so that we can address whatever questions may come forward. This is briefly what we're going to be doing this afternoon. The first is a brief overview of everyday resilience. And I think some of you will be very familiar with the concepts, and for some of you, it might be fairly new. Then I'll dive a bit deeper into the capacities for collective action, which is kind of more my area of focus. Then I'm going to talk about a case study, thing I was involved in here in Cape Town called the Vaxi Taxi, and discuss some of the kind of analysis that is in progress to give an example of how one would go about applying the capacities framework to trying to understand how to build more resilience in a system. And then after that, we should have some time for discussion. And I really look forward to hearing from you and hearing about whether these ideas resonate, if you have tried similar things in your setting, and any other ideas you might want to bring into the mix.
So Leanne, I don't know if you want, we are still seeing your viewer mode. So we are also able to see your notes.
Okay. I wonder why that is. Let me try again. And now?
It's still loading. I'll let you know.
Okay.
Yes, now it's perfect.
I'm using a colleague. Okay, great. I'm using a colleague's computer, so I'm sort of fumbling around a little bit. Yeah. Great, though. I'm glad. All right. So to start with a definition of everyday resilience. And I heard you, Dintle, saying some of the previous webinars of SysTech have been thinking about how to apply a systems lens to the health system. And everyday resilience takes that as its starting point. So it recognizes health systems as complex, adaptive systems that are unpredictable. And it, in fact, would see everyday resilience as an emergent property of a complex, adaptive system. So just to situate that in what it sounds like you guys have been already discussing over the past few months. Resilience is this idea that health systems absorb and respond to chronic strain through renewal and reorganization to emerge from the challenge strengthened and more resourceful. And I guess quite an important distinction to make, and one of the ways in which resilience is often critiqued, is that it's certainly not about becoming more and more resilient to systems that are increasingly unjust. Instead, it recognizes that all health systems will constantly be responding to a series of acute shocks and chronic stresses or strains. And actually, the way that we respond to these inevitable stresses is extremely important and is a way in which we can develop more everyday resilience. So just to make that distinction. I think one of the important areas of work is that it really is something that requires new forms of leadership. So it's not the kind of, I guess, quality of a system that works very well with command and control forms of leadership. It's one that really requires much more flattening of hierarchies, new forms of leadership that embody respect and empower others, particularly frontline healthcare staff, as well as the social networks and relationships across, within, and outside of the health system. So it really does take a much broader view. And then I think lastly, it's often I think one of the helpful ways of thinking about it is that it's not about what a system has. So it's not about saying we don't have enough resources, but it's about what we do with the resources that we have. So it's not a function of what a system has, but of what it does and how it does it. And then on this slide, I've put some of the kind of key references that I've been using both in my PhD and for today's presentation, most of which are from the continent, which is great. I think some of you might know Dr. Barasa, who's a colleague, also a longtime colleague and friend. As Dintle said, we've worked together for many years. And in this paper in Health Policy and Planning, they talk about from bouncing back to nurturing emergence, reframing the concept of resilience. And so that's a paper that kind of recognizes and critiques a little bit how resilience has been a bit of a buzzword in global health, but recognizes that responding to chronic stress, acute shocks, inevitable in any health system, and that how we do it is about more than bouncing back, and it's about nurturing emergence. And I guess that's quite a nice reference for those of you who are interested. And then one work I was involved in here with my colleague, Lucy Gilson, about organizational change and everyday health systems resilience lessons from Cape Town. So that's from an embedded research project that we did. And I think I put the WHO position paper here as well, because every time we have a big pandemic, whether it's Ebola or now with the global pandemic, there's this sort of this resurgence of the importance of building health systems that are resilient and responsive. This is the conceptual framework that we have used over the last kind of 5 or 10 years. And I guess just to give you a bit of a helicopter view, the idea is that a health system will face a stress, and that could be a shock like Ebola or COVID, or a chronic stress like human resource shortage or budget cuts or staff morale issues. And that the way we respond as individuals, but more importantly as teams, can be either in an absorptive way, so we just kind of do what we can to weather the storm. And often that's where one individual, like for example, if there's a chronic shortage of nurses, you'll have one nurse seeing 40, 50, 60 patients a day and just absorbing that HR shock. That doesn't lead to systems that are more resilient, because of course that person can only continue for so long until they also burn out. So the absorptive way of responding is when we sort of just absorb the shock, do the best we can, but do nothing really to change the kind of the way we do business, shall we say. The second is adaptive. And so that is when we do adapt and do things quite differently. So for example, a nurse might redeploy one of the nurses in the emergency room or call in somebody from sick leave to come and assist. Whereas transformative is where we shift the way the system operates and we fundamentally do things differently. And so those are the 3 categories for how we respond to shocks or stresses. And the effect then is thought to be either we build more resilience, or sometimes the way in which we respond leads to something known as maladaptive emergence. And that really means that sort of like a good example perhaps is where in a hospital where there are no, where the pharmacy is dysfunctional and potentially not even available at all, you might find nurses start initially buying drugs to sell to patients so that patients have medicines, for example. And that would be seen as a bit of an adaptive strategy. But if that then sort of unfolds into a parallel system within the pharmacy and inflated prices where patients are actually exploited and charged much more for medicines than they should be, that would be an example of maladaptive emergence, where what was intended as a way to respond to the shock actually becomes something that's quite harmful to the health system and the people it serves. So as I said, we are really going to be focusing on the capacities, which I'm going to dive into next. And the thinking there is that resilience is about building the muscle to respond to the next crisis or stressor. And actually that muscle, how we build that muscle, is nurturing the capacities. So these are the capacities. And the idea is that these 3 capacities are interactive. And it's not sort of, they are in the way health systems are complex and emergent. These are all kind of interconnected and interacting all the time. But the categorization is just to kind of make sense of the broader ideas. So the 3 are, firstly, in the pink, you can see the cognitive, and that has to do with, in a sense, how we think collectively, right? So these are all collective capacities. None of these are individual attributes. This is what we nurture in teams. And the cognitive capacity is really the mental models that we use as teams to think through, interpret, analyze a particular shock or stressor, come up with a range of alternatives, and select the most appropriate one. So it's about how we think about shock, stresses, issues, the world in which we live, as a team. And some of the subcategories there are something called positive conceptual orientation. And that really is this kind of can-do attitude where you are in teams not looking at what we can't do, but what we can do, even despite some of the challenges. Constructive sense-making, for those of you who haven't come across it, is sort of a mechanism through which we get on the same page about things. Obviously, a team of people might come at a problem in a range of different ways, and constructive sense-making sessions are the way in which we hold meetings, the way in which we come together, such that we start to have similar ways of understanding, making sense of, and finding solutions for some of the challenges we face in our health system. And then the last one there, purposeful framing, is about the language we use in the organization. And that has to do with the way in which we frame challenges, in meetings, in documents, in corridor conversations, maybe over coffee, or for those who still smoke, a cigarette break outside. It's the way we talk about our organization and the stories we tell ourselves and each other. So that purposeful framing also speaks to how the language we use underpins what we ultimately believe to be possible when it comes about bringing about change in the health system. So that's the cognitive, shortly, how we think. The behavioral is kind of what we do. And the idea there is that we generate kind of almost like a toolbox of possible actions from which to draw. And some of the subcategories of the behavioral capacity are a sense of learned resourcefulness. So I think that's important because sometimes people feel like as a health system in a rural area with hardly any resources, it's not possible. But the learned resourcefulness is really about how it actually is, irrespective of where you are. You know, these things can be applied across contexts. And the learned resourcefulness is about how every time we respond, we kind of can get better at that. And I think those of you who have worked on multiple challenges in the health system will see that, especially when things have gone well, then people often feel like we can make a difference. We actually can change this. So that learned resourcefulness is a capacity that's thought to be quite important, because the opposite is also true, right? When you are constantly up against bureaucracies that just never seem to shift, never seem to change, then it's very common and very easy and very understandable to become very sort of disillusioned about what is or isn't possible in our health system. The next is ingenuity and bricolage. And so that's really where we take what we have and we sort of use it in a different way to respond to something. Counterintuitive agility is where we recognize, again, as a collective, that this particular situation calls on something totally different. So even though we maybe have a particular way of doing things usually, in our sense-making sessions, we recognize that this circumstance calls for something totally different. The next is useful practical habits. And the idea there is that there are ways in which first responses to any crisis can be sort of habits within the system. So sometimes a fire drill is an example of that, for example, you know, where everybody's, if you have sort of safety measures in place in your facility. And I know some people do, some people don't, but that first response, so that you can sort of catch your breath, have a think about what might be the right way to respond, is also seen to be an important capacity. Behavioral preparedness is where you take actions before crisis hits. So, for example, some of the ways in which countries on the continent are thinking about what will we do when we have another pandemic? What are the things we've learned from COVID to respond differently, in the way that some groups who really weathered the Ebola pandemic thought very carefully about how to respond differently next time. So Nigeria, I think, did a lot of work on what they learned from the response to the Ebola pandemic and how that could prepare them for the next inevitable shock. And so I guess the ability to do that of a system is known as behavioral preparedness. And then that last bit is about nurturing this tension between creativity and well-rehearsed routines. Sorry, not well-rehearsed routines. So I guess doing things differently, there's a tension there between doing what we always do. And in systems, often people are much more used to doing what we always do. And so creating an environment of psychological safety, which is one where we have positive conceptual orientation, etc., is often needed to recognize that this time we need to do something quite different. Then lastly, the contextual capacity is made up of these kind of 4 components. And I think what's important here is that this contextual capacity is almost like the soil in which responses grow. So the cognitive and behavioral and contextual, they are all interconnected, as I said, but the basis of that is the contextual capacity, in that this is where relationships really are formed. This is the capacity that speaks to deep social capital, both within teams, but also between the health system and potential collaborators or networks. It speaks to this idea of broad resource networks on which to draw. And that varies from setting to setting, but it's recognizing that a health system is more than just a facility. And actually, to be resilient, we need to very specifically and intentionally develop networks with other actors in that broader health system, so that when we do need to respond in crisis moments, we kind of have these larger resource networks on which to draw. The last one there is diffuse, or the second last one rather, is diffuse power and accountability. And that kind of links to what I mentioned earlier about how this is really about having much flatter hierarchies than we often have in our health systems, where we don't have a situation of, the doctor is the decision maker and instructs others what to do, but members of the team all feel that they can bring something to the table and are all accountable, and all find that there is space for them to bring their ideas and creativity in how the response is formulated. And then the last is psychological safety. And that really is, I guess, knowing that that it's okay to make mistakes, and that mistakes aren't failures, but that they are opportunities for learning. And that kind of framing links back to purposeful framing. So in some contexts where mistakes are made, there are consequences, disciplinary consequences must be taken. For example, there's often a phrase used in my setting, but the framing of, actually mistakes are opportunities to learn, and let's unpack what happened and what we can learn from that, as opposed to disciplinary action as the next step, is an example of purposeful framing and the language that we use in an organization. So with that, which I know can feel like a real mouthful because it is quite a lot of theory heavy stuff, I'm going to briefly talk to you about an initiative I was involved in as a case to demonstrate some of the capacities, how we use them, or rather how we can think about an experience using the capacities lens to think about how we might build capacities in the system, such that we're in a better place to respond next time. So should I just pause there, actually, because I can't see any hands? Should I just pause there to make sure that things are, you guys are all with me, all clear? Are we happy for me to continue?
Yeah. So maybe you can pause a little bit, Leanne. I don't see any hand per se, or any question on the chat. But I was just wondering whether, in a way, so there's often these tendencies to have, like you were saying, currently everybody is really talking about moving to health systems that are resilient, again, emanating from what we experienced during the COVID era, what people have gone through with the Ebola situations and so on. But the other buzzword that is also doing rounds around there is, health systems readiness. Are you able in any way to speak to the two concepts in terms of how they really converge?
So to be honest, health systems readiness is not something I have much exposure to. I guess if we were to apply this framework to that idea, at least, it would be a bit about the behavioral preparedness, but it may be that much more is meant by the health system readiness framing, and it's actually not something that I've really come across. Dintle. So I think, probably better for me not to say too much on that, but let me leave it there.
Okay, great. No,
it's a good
thanks.
question.
Thanks.
Perhaps somebody else has ideas to share.
Yeah. Okay. Otherwise, I don't see any hand up or any comments, so maybe we can move on.
Brilliant. Great, let's do that. So the EMS Vaccine Taxi, can I first ask if any of you guys heard of this in your corners of the continent, or is this sort of something I'm also sharing for the first time? Maybe put a hand up if you heard of it before, perhaps.
Okay, I don't see any hands.
No hands. Okay, great. All right. So then I'll explain it from the beginning. Thanks, Sinclair. So I guess, sorry, did somebody want to make a comment?
No, Prof, I don't think you were trying to say anything. You are unmuted, by the way, Prof. Muna. Yeah, no, go ahead.
Cool. Thanks, Sinclair. Thank you. So the EMS Vaccine Taxi, I guess, for us was quite an exciting initiative because ambulance crews had never been involved in vaccination efforts before. And I'm not sure if that's also the case in your settings, but in South Africa, ambulance crews have really just been about responding to emergencies overall, even though in practice we see them doing a lot of other things. But I guess we'd never been involved in vaccination efforts before COVID. And during the pandemic, we really saw this as an opportunity to do things differently. And so in terms of the framing I'm using in my PhD research, we're looking at the Vaccine Taxi as a potentially transformative strategy because of the initial conceptual framework I described in the beginning, and because of the ways in which it nurtured capacities, which we have seen at play after the kind of vaccination efforts. So just to give you a bit of background, in January 2021, there was no sign of South Africa getting COVID-19 vaccines. And I know the same was true, but actually much worse on other parts of the continent. And by comparison, South Africa was very lucky and very privileged to get vaccines when they did. But I'm sure you will recall back to that January 2021 when the rest of the world was getting, wide. There was I think we had some countries with 4 times the number of vaccines that they needed, but yet very few people on this continent had been vaccinated. And so although South Africa was fortunate enough to get vaccines sooner than a lot of other countries on the continent, in January, the talk was there was no way we were getting vaccines anytime soon. And the predicted date was actually September 2022. But then suddenly, over the course of a weekend, unexpectedly, we got an announcement that the healthcare worker vaccination program, known as the Sisonke trial, was due to start. And on the 17th of February, our president was vaccinated in Khayelitsha at Khayelitsha District Hospital on national television as the first person to get a vaccine as part of the Sisonke trial. And so suddenly the health system had to rapidly take action because there was no infrastructure for a mass vaccination program of this nature. In EMS, even though traditionally we wouldn't vaccinate, we were very committed to be part of the COVID-19 response. And so we actually first converted the vehicle workshop, actually where I'm sitting now, just a few doors down, the place where we usually do ambulance maintenance. We converted that, we took all the cars out, we covered up some of the areas where you would usually climb underneath the vehicle, put some boards down, and within a matter of weeks, converted it into a mass vaccination unit. And in the end, vaccinated almost 40,000 people there. But what we saw was that after about 5 months, it was very clear that many people were unable to access vaccines. And I know that South Africa is in a better place socioeconomically than many of your settings. But I think because we have such extreme inequality and such a weak primary care platform within informal settlements, farms, and a lot of places that weren't in the metros, people were really struggling to access vaccines. And so we decided we needed to adapt the model, and our ambulances became mobile vaccine units, which we called the Vaxi Taxi. So this is just a little bit of a graph to show the timing of all of these things. So as I said, end of January, we were told there's no way we're getting vaccines up until 2022 in September. Then suddenly over the weekend, they were like, we're vaccinating next week. And we had to rapidly jump into action. Then as the healthcare workers were vaccinated in this kind of interwave period between our second and third wave, the EMS Max Vaccination Center was set up. And as the numbers started to decline, we were able to adapt the model and go mobile, sort of take our show on the road. And I think the reason I'm putting it here is because that ability to adapt, we really sort of reflect on the capacities that we built while we were running the mass vaccination center as crucial to the ability to adapt and actually go mobile. So it's a nice example because it demonstrates to us that the capacities that you nurture and build in one response can enable the next one. So this was the Vaxi Taxi model, very, very simple. Pulled up 2 ambulances, put a tarpaulin over the top, some chairs in between, and it meant we could set up wherever we needed to. We vaccinated all over the province, and really the idea was to take vaccines to where people are. So a lot of our collaborations were with community kitchens because, as I'm sure is the case in many of your settings, the pandemic, the kind of so-called second pandemic, was that of extreme food insecurity. And so we had a lot of community kitchens set up across the city. And what we did is worked with the woman who ran those kitchens. The people would get a hot meal, and then if they wanted, afterwards they would get a vaccine. So you can see below there's my colleague Aslam helping this elderly gogo to the ambulance so that she can get a vaccine. We went to farms, we went onto ships, we went to sort of dusty end of the roads in central Karoo. We went to a lot of informal settlements. And I guess the simplicity of this model, where you just needed 2 or 3 ambulances, meant we really could go anywhere. And we could not keep up with the demand. Where other people were talking about vaccine hesitancy, we just had so many requests and so many people. During a lunch slot, we'd vaccinate about 250, 300 people. And so we really saw the value of taking vaccines to where people are. I think the way that I want to tell this story, to link it back to the capacity analysis, is that the initial focus of the Vaxi Taxi was really about transitioning from this max vaccination site to the Vaxi Taxi. And this involved testing the model here at our fixed site. So we did a mock setup in the parking lots, and we asked people coming to get vaccinated to come into the Vaxi Taxi rather than into the formal settled center. So we could figure out how to get the best flow, how to make sure people were waiting for the shortest amount of time, the best way to do the cold chain so that we could guarantee the vaccines were still going to be effective. And we then took that model that we developed here to community kitchens to test it out in areas where many of my colleagues were afraid to go, to be honest. One of the things we really struggle with here in Cape Town is our ambulance crews get attacked and held up at gunpoint quite a lot. And so many of my colleagues were really worried that it wasn't going to be safe. And because vaccines were so difficult to get at that point, people were convinced we were going to get robbed and that vaccines were like liquid gold and we were going to get robbed for the vaccines. In the end, that didn't happen. We were held up once, but not for the vaccines. But that kind of behavioral preparedness meant that by the time the fixed site was closed, as you saw in that graph, as the numbers were declining, we could roll out the Vaxi Taxi provincially. So that was sort of the first phase, is almost that transition and doing the behavioral preparedness work required to take the vaccines out to the people who needed them most. In the second phase, as a way to kickstart the program, we had a boot camp here for 9 districts across the province. So to give you guys a sense of the geographic spread, the folks who came from the furthest points in the central Karoo had about a 9-hour drive to come and join So it wasn't all local. We had people coming from across the province, for those who haven't spent much time in the Western Cape, to come, get the training, and then get support to set up a unit in their district. So it was also a way of, I guess, rolling out provincially, and this idea of working at scale, but without scaling up in the traditional sense, because each district has a completely different set of challenges. They have different struggles in terms of road access, in terms of different benefits, in terms of existing relationships with communities, etc. But the idea was that they would adapt that themselves based on what makes sense in their context. So this Vaxi-Taxi structure was made up of these 9 autonomous teams who had the freedom to run their project in whatever way they felt was needed. But there were some connecting points provincially, both to offer some support from a logistics perspective, but also to enable learning from one another throughout. The other important point to make is that what the staff we used to run the Vaxi-Taxi were colleagues who were unable to perform routine EMS duties. So either because they had been booked off on incapacity leave before the pandemic, or because they were kind of considered too high risk to have a patient-facing role because of their comorbid illness. So it really was also a way to draw on resources within EMS who, without taking sort of active members off the road. So during the first 6 months, the Vaxi-Taxi visited over 180 neighborhoods and vaccinated close to 15,000 people, community kitchens, school halls, churches, cargo ships, many other community structures. A Vaxi-Taxi, yeah. Was it a question or a comment? All right, I'm going to continue. We can come back to that. But yeah, Vaxi-Taxi was what we called our vaccine center on wheels, the kind of ambulance converted into a vaccination center. And this is colleagues in the Witzenberg. So this is a very rural part of the Cape Winelands district. What this team did was adapt their model, because there are many places within the Cape Winelands called slaapdorpies, which translates to towns where people only come to sleep. And because the major livelihood in that area is working on wine farms, many people are at work all day and only get back in the evenings, kind of usually quite late at night, to come and sleep before going back early to work again. And they weren't given time off to get vaccinated. And so this team decided to start having evening vaccination events in these slaapdorpies so that people could get vaccinated without losing a day of wage. So just, I guess the point I'm trying to make is there were really ways in which the teams were able to be extremely flexible, really look at community networks and how to kind of, how to build support where there was hesitancy, but that wasn't really an issue for us, but really just to be as adaptive as possible in that particular moment in the pandemic where a lot of people were still dying from COVID. So that brings me to a little recap. So when we talk about building the muscle for the next crisis, which really is the kind of essence of how the kind of everyday resilience is built, what we mean by that is nurturing these 3 interacting capacities, because it's those capacities that underpin collective action. And so I'm now going to talk about which of these capacities we saw explaining the Vaxi-Taxi experience. And so these diagrams, I know, are there's a lot going on, and I'm not going to cover everything, but I'm just going to use them to demonstrate the kind of analytic approach and to highlight some of the key areas. So I think this sort of shows, this particular diagram shows the way in which the provincial Vaxi-Taxi, the first diagram here on your left, built a series of capacities from which the Cape Winelands Vaxi-Taxi could learn. But the Cape Winelands Vaxi-Taxi was able to sort of make it their own in their area. And I guess we set out to vaccinate. What we saw unexpectedly is that we built other capacities we wouldn't have anticipated. And the first is that our relationships across the health system significantly improved. So usually EMS is kind of what some people call the orphan of the health system. You know, I'm not sure what it's like in your context, but ambulance crews are often treated quite badly when they arrive at hospitals with patients. They're often treated as like sort of very low level workers within the health system. And what we saw during the vaccine efforts is that paramedics and other ambulance crews had a seat at the table just like anybody else. Pharmacists worked overtime to make space to sort of allow some of the programs. Doctors would come to hospitals specifically to come and test Vaxi-Taxi members who maybe had COVID to help get things back on the road. We saw these incredible relationships being built across the health system, which was a capacity, a contextual capacity, which was an unexpected consequence of this initiative. And then the last was this idea of Vaxi-Taxi as a place of healing. And I'm going to come back to that idea in a moment, but I'll just sort of plant it there for now. So this is the analysis of the provincial Vaxi-Taxi. And I know that it's quite a lot and it might be way too conceptual. So I'm going to talk through some of it. I do hope it makes sense, but also lots of time for questions if there's anything I can do a better job of explaining. But essentially, in the center of the diagram, you can see there the three interacting capacities. So we've got cognitive in pink, behavioral in blue, and then contextual in green. The boxes with the dotted lines are the capacities that we developed in the fixed vaccination site, which then spilled over or were drawn on in the Vaxi-Taxi experience. So, for example, there was this deep sense of collective purpose amongst the team. We sort of had about 100 people working in the fixed sites who came from different parts of the province. And there was this real sense of being part of this historic moment. So you can see in that quotation there, we were part of history. And really, that kind of sense of deep collective purpose that it was really worth doing. We saw that spilling over into the Vaxi-Taxi. And so people were fired up to go out there and be part of history, bring vaccines to people who needed them most so that we could finally get on top of the pandemic. It feels strange to think of now because our world is so different. But back then, that was kind of a really strong driving force. So those dotted lines around the edge of the diagram are where we drew on capacities developed in the fixed sites to enable the provincial Vaxi-Taxi. Then the boxes that have the dark black line around them are the key drivers of the experience. So I'm going to focus on that triangle you can see on the bottom. And that's, I think, nice because it demonstrates a space where the three capacities are really interacting. As I mentioned earlier, a lot of the people who were part of the vaccination efforts were on incapacity leave. And that's because we have a huge number of staff on PTSD leave because they've been held up at gunpoint, sexually assaulted, robbed, and have just been unable to return back to work out of fear of what might happen out there. We have a couple of parts of the city where it's particularly violent. And this extreme mistrust of being attacked again, my colleagues really had to get over that in order to get out there. And it was very difficult for some of them to make the shift. The other kind of big mindset shift required was that EMS had just pulled off this incredible thing in the vaccine fixed site. And having never vaccinated before, but having done so well, people were very worried that if we took things on the road, we were going to mess up and it was going to tarnish our name, you know? And so there were these two ways in which we had to shift our mindsets, which is a very important cognitive capacity in order to enable this project. And what we saw was a lot of those mindset shifts happened in what I'm calling the spaces we created for unlearning. So we often talk about the importance of learning in a health system, but I think what we really saw here was that unlearning some of our preconceived ideas is just as important as learning. And in these spaces for unlearning, we saw these mindset shifts. And those spaces for unlearning were often in these community kitchens. And the kind of the CAN community kitchens are a group that I worked with, a sort of community-led response to COVID. And we knew that we could trust that people running those kitchens would look after the ambulance crews. We knew that they were so well known in their neighborhood that nobody would attack an ambulance who was being hosted by this community group. And so creating this space for unlearning where people felt safe and then could learn to think differently about things more broadly was a very important driver. And the kind of third part of the triangle is the broad resource networks. And those resource networks are the community groups that we worked with, as I've mentioned, but also other parts of the health system that we had developed relationships with through the work in the fixed sites, like our pharmacists or the vaccine project office, who wouldn't have trusted EMS if we hadn't already done the fixed site. And so one of the other things I have there in the dotted line is that EMS almost earned its vaccination stripes in this fixed site. And we developed a sense of legitimacy that meant the department supported us to do what at that time was seen as very unusual, even though I'm very well aware that in many parts of the continent, and I'm sure in your settings, mobile health is not new. But in our setting, ambulance had never done it before. And there was, at that time, there was no mobile COVID vaccinations because everybody was worried about safety and was worried about cold chain. But I think it's because in South Africa, the same challenges. I know when I worked in Sierra Leone, we had loads of mobile vaccination units. So it was particular to South Africa, but here it really was important to earn our stripes so that we were trusted to take this kind of model on the road. This is my last slide. So if it is feeling like I'm talking nonstop, I apologize. A few points here, and then I'm going to stop and open up for broader discussion. I'm really looking forward to what you guys, what you think of all of this. So this is the Cape Winelands Vaxi Taxi, which is the picture I showed, and it's the crews who did the slop door piece, and it's the crews who, let me go back a few slides. If you look at this graph at the bottom, when the other teams kind of lost their steam, the yellow bars is the Cape Winelands team. They just kept on going. And in fact, up until a few weeks ago, they were still vaccinating. And so it felt important to do a capacities analysis of that initiative, understand what has sustained this team, what capacities have they drawn on to keep doing this incredible work when many other people have stopped. And the reason many other people stopped was because there was always this competing sort of demand of operational work that ambulance crews usually do. And so people were unable to justify continuously having, more and more people involved in the vaccination efforts where we were needing to do our sort of routine, more core mandate type work. But the Cape Winelands guys continued. And one of the reasons they could do that was because they had this dedicated team of people, all of whom were previously on incapacity leave because they couldn't work either from PTSD or comorbid illness, etc. And so one of the key drivers there is a contextual capacity that I'm calling slack in the system. And so we sometimes talk about how important it is for health systems to be efficient and to be lean. But I think what we really saw here was that if you can draw on existing resources and find ways for them to play a different role, then actually that capacity is a really important driver or explainer of how to make initiatives such as this impossible. The other kind of three big sort of drivers was, one, the deep social capital within the team. So this is a team of people who became like family. And many of them talk about how that one of them has this great quote saying, "This is the best ride of my life, and it's because of this team." And I think just to put it in perspective, some of these colleagues hadn't worked for a number of years. And so suddenly being part of this initiative where there was such an important purpose really just re-inspired and reinvigorated and reminded people why they started working in health in the first place. That coupled with this like family almost type structure meant they were accountable to each other and accountable to all of the neighborhoods in which they were working. So that was a key capacity that they developed, because prior to the Vaxi Taxi, these people had never worked together because they were in different districts. And so that was a capacity they developed. The other big one is, again, same as the previous one, shifting mindsets. And because people were so afraid of getting attacked out there, held up at gunpoint, it took a while. And so once people kind of had this perception that actually we can do this and we are safe, and that coupled with this purpose that was reignited, was a key contextual or key cognitive capacity that interplayed with the contextual capacity. And then my last point is, again, to bring you to the triangle at the top left of this diagram. So again, that's where we have a sort of an example of how things are interacting. one of the things that this team chose to put in place was a weekly reflective session. And so they put a routine in place for themselves, where on Mondays they planned, they did events on Tuesday, Wednesdays, and Thursdays. And on Fridays, they sat together to reflect specifically on the lessons they'd learned that week, what to do differently, how to support each other better, how to work with sort of community groups better. And in this weekly reflective session, there was a lot of constructive sense making, which is one of the cognitive capacities I mentioned earlier, which also was able to breed collective purpose and a purposeful reframing and the kind of can-do attitude. And so this kind of reflective session that was a sense-making space, we now see as a key driver of what kind of kept this team going for, you know, almost 2 years, even when many other people had already stopped. So I think I'm going to leave it there so that there is sufficient time for comments and questions. Let me pop on my video. And yeah, I'm ready to hear your thoughts, maybe hear some reflections from your own setting or some questions that you might have. I see one in the chat box. Thank you so much. Let me have a quick read of that.
Yeah, so thank you so much, Lian. We've had a couple of comments in the chat from Victor, from Mamutsi, from Senzeni, Dr. Ramabu. I don't know if any one of you would like to speak to your question or your comment. We can also read them through, but if you really would love to speak to your question, please go ahead and do that.
Good afternoon. Thank you so much, Lian, for such a brilliant presentation. And I think for me, the transformative is the way, and I'm seeing how it has been able to enable the services to be able to reach the clients. Currently in Botswana, we are undergoing a sustainability analysis in our healthcare system because the funds are literally kind of going down. And we are encouraged to provide services without compromising on the quality of care. So I'm really wondering how your model has factored that in, sustainability into it. And plus the latest language now is community-led monitoring as well. So I don't know how those two are being factored in, because the community is encouraged to play a key role in how they are provided the services. Thank you.
Great, thank you so much, Dr. Ramabulian. I don't know if you want to take each question or you want to take a couple and then respond, or maybe you can go ahead and speak to Dr. Ramabu's point.
Let's take a couple, and I'll make some notes, and then in case there are common themes across, then I can speak to some of the points. Thanks, Senzeni.
Okay. Great, thanks. Senzeni, do you want to speak to your question?
I think I'll speak to the last one that I sent to say, when she was presenting, she spoke about a very interesting point to say some of the staff workers, the health workers, especially the ambulance staff, I don't remember how she actually mentioned them. She said they were actually sort of like excited to find relevance and, you know, find a lot of input in the health sector. So I was like asking the question to say, in this context, how did you then, after the program was complete, almost complete, when the program was dying down, how did you keep that staff morale and motivation for them to not go back into the old culture of them not finding their relevance in the health system?
Okay, thank you very much. Victor, do you want to speak to your questions and comments as you place them on the chat?
Yeah, thank you very much for that, and thanks, Radhi, for that fantastic presentation. And I like the transformative aspect that you gave to it and coming up with the vaccine-taxi kind of model. I was just wondering how you're able to balance the need to vaccinate using the vaccine-taxi model versus the emergency medical needs on other parts which were not really in line with the vaccination. Or because I'm asking that because the availability of ambulances in different parts of Africa could be scarce. And if they are available, then they are expensive. So how did you manage that? My second question, which is just out of interest, is comparing with the no vaccine taxi case scenario. How will you quantify your impact? And if you also
Can you
have...
just explain that question, explain a bit more so I have a better sense of what you mean?
Oh yeah, so what I mean is because this model is quite unique, and I wanted to understand if you've had any comparative analysis of what impacts on outcomes you had with what other countries did without the vaccine taxi, or assuming that we didn't use the ambulances to reach people in the community, how much impact would that be? Yeah, I don't know whether it's a bit more clear. Thank you.
Thank you. Perfect.
Great. Thank you very much, Victor. Leanne, do you want to take those three and then we will do another round if there are any more?
Yeah, sure. I think I'll take the easier ones first and then dive into the sticky ones, noticing that we are recording. So some of these answers require a level of honesty that reflect the bureaucracies and power within our health systems. But in terms of the kind of comparative analysis, Victor, that you kind of asked, we're not aware of other emergency services having done it. And actually, Dr. Tedros came to visit us because he was very excited to hear about this model. And at that point, there weren't other teams doing it. I'm not sure if that changed. We haven't really heard of others doing it. So there wasn't really space for any analysis of that kind. In terms of our impact, I think we vaccinated people who would otherwise not have been vaccinated. And so some people will see that as impact. If you look at the number of people we vaccinated compared to the broader provincial program, it's a tiny, tiny fraction. It really is such a small amount, but yet we generated so much more sort of media interest, requests. And I think that's also quite interesting, you know, and many people who were fearful of the vaccine, they watched us for the whole day, then they got vaccinated, and then their family came to a fixed site. So I think there's ways in which we shifted how people felt about the vaccine in ways that are a bit unmeasurable, you know, that thing that sometimes the things that count the most are the things we can't count. What we did before each event is we did door-to-door mobilization. So myself and a couple of other colleagues in Green teamed up with the community leader of that area, and we literally spent hours knocking on every single door, telling people that we'd be there tomorrow. And essentially it would be like, hi, we brought you a doctor from EMS. She wants to know if you have any questions, because often we'd be in areas where Xhosa was sometimes the only language people spoke. And then we would have a sort of a very friendly conversation that actually ended up shifting how people felt about getting vaccines, especially when there was a lot of distrust in the beginning. And I think for me, the impact lies there in the building of trust. And then the last point I want to say about impact, which I know it's a different way to talk about impact to how we would usually discuss this, is that when we push to do this vaccine taxi, yes, we wanted to take vaccines to people who otherwise wouldn't get vaccinated, but we also had a bigger goal, and that was to build trust with community groups, given that there is such a massive trust deficit in South Africa between the public and government services. And so we really saw the vaccine taxi as a kind of literal and metaphorical vehicle to build relationships with communities so that we have more trust networks. And we've seen that impact. For example, we've had ambulance crews arrive in the middle of the night on a dark street in Khayelitsha, and we've had a whole street of people come out with their cell phone lights on to light the way for us. And then they've said, my grandmother got vaccinated with you guys, and I think she would have been dead otherwise. We're so grateful. And so there's these small, you could call anecdotal examples of where things have shifted. But I think in a context where it is becoming increasingly unsafe for our ambulance crews to work in particular neighborhoods, that impact is something that's very important to us. So I guess that's what I would say about impact. I hope that sort of, even though it might not be how we usually just think about impact, I hope that that makes sense, Victor. In terms of the balancing of vaccination services and emergency services, thanks for the thumbs up. It was a struggle in the beginning. It has remained a struggle. And in the end, the last Vaxi Taxi got shut down actually, because it was seen as not our core mandate. And I think it's a difficult call, in the midst of the pandemic, where actually you could argue that us vaccinating was an incredibly important step, because then one more person vaccinated was one less person we needed to take to hospital. Managers were willing to get behind the idea, but there are still managers in my service, my colleagues, who feel that we never should have done this, that this was outside of EMS's core mandates, and that actually we should have focused on our core business, which is emergency care. In equal measure, there are managers who feel like the fact that we could change how staff feel about their role in the health system and get them excited about it is reason enough to have done this Vaxi Taxi. The fact that we have improved relationships with other parts of the health system. Now, when we arrive at a hospital, often doctors will know, or nurses will know, the ambulance crews by their first names, because they've worked together now on a vaccination effort. So some of the managers feel like the relationships that we built, or the contextual capacity, was worth it, even though they might not agree that vaccinating was necessarily part of our role. But I think if you look at global trends of the way emergency medical services is shifting, it's recognizing that it's actually more a part of community health services than it is of health services. So I guess my view is the Vaxi Taxi was very much in line with some of the global shifts we see, but not all of my colleagues agree, and there have been intense debates. And the Vaxi Taxi program received additional funding, because that's the other thing that speaks to the first question on sustainability. In the beginning, we didn't get any extra funding to do this work. We did it with the resources we already had. So I guess, like, in some ways, that was an example of how you do things differently with the resources you already have. But what we've seen is, we haven't been able to sustain those vaccination efforts, but also because the landscape has shifted. So it doesn't make sense for this to be our number one priority at this point, because there's other things to focus on. So I guess the balancing act has always been difficult. And even when we were starting, there was a lot of resistance to this for a number of reasons. But then, because it generated so much public support, and in the end, Tedros came, it won a Public Service Excellence Award. The ministers got very excited about it. It was at a lot of the political kind of leaders really felt that it was, it served their short-term goals in some areas, but in other areas demonstrated a public service that was in fact reaching people who were usually left behind. Our Minister of Health is a nurse who talks about leave no one behind. And so this was an initiative that really sought to do that. So it in some ways, it got so much support outside EMS that it was impossible to close it down initially. But now that, things have shifted and we're obviously in a very different phase of the pandemic, that's no longer the case. But that balancing act, it was not, there were intense discussions. Some might call them fights about that. And then in terms of what was done to keep healthcare workers motivated, I think Senzeni, that was your question. While the Cape Winelands team was active, the way in which they kept one another motivated was the key mechanism, actually. They had a very supportive manager and a very supportive district manager. But the district manager, for example, talks about his role as the guy who sits behind the curtains and makes sure the lights are kept on. But he gave total autonomy to the team, and they were so excited to have freedom. One of them talks about how we've always been MacGyvers out here, but we've never actually had the freedom to use those skills. Now we can with the Vaxi Taxi, and that's why this is the best ride of my life. So the kind of motivation and morale was largely underpinned by the freedom that they were given, and the freedom that they, in some ways, continuously earned with each new event. Once once the kind of, Victor's question about the balance, once it was seen as, vaccination was seen as less important. And I mean, even the last one, that last team I spoke to, those EMS colleagues have they've been sent back to the roles that they performed prior to the Vaxi Taxi. And in many instances, they are very unhappy, and there hasn't been efforts to sustain sort of the kind of enthusiasm and renewed passion. I think we'll see what they do. At the moment, they're very upset that this thing they love so much has been closed down. And again, there were intense discussions about whether that should happen or not, but there wasn't a consistent effort really for those healthcare workers. And I think it's an example of where health systems, as these big bureaucracies, often aren't very good at taking care of individuals within the system. So I think we saw the Vaxi Taxi almost creating a buffer from some of that, such that we could, build collective spirit and purpose. And in a more formal bureaucratic structure, that's much harder to do. Not impossible, but much harder to do. And then the last point on the sustainability of it, I mean, I think
Maybe
it
not
really does
interfering.
depend.
Oh,
Say again.
sorry. No, I was saying why I raised the question is that sometimes, when you have new programs, that we get the people are excited, they join in, they produce results, and at the end of the program, it's sort of like and they excite us. We move along with them. Yeah. So it's quite important for us to actually maintain also important.
Yeah, Senzeni, I mean, I completely agree. I think those are all very good points. I guess often when we talk about the importance of sustainability, it's often with an external funding or an external donor or MPO funding a project. Whereas in this case, it was within the public health service. So we do think about it a bit differently in a sense, because we were using resources that were, for example, everybody who worked on the Vaxi Taxi, they were already getting a salary anyway, but they weren't in a place where they could contribute as much as they did when they joined the Vaxi Taxi, for example. We received grant funding, obviously, for some of the running costs, but it was very minimal, actually, because even with our ambulances, what we did is we repurposed existing ambulances, and that was a struggle, especially in areas where we don't have enough ambulances, which is most of the province. There were times where we didn't have enough ambulances to respond to emergencies and also vaccinate. And so it was always difficult. Had we received additional funding for the project, I think that would have meant we could have vaccinated a lot more people. I guess also in the pandemic moment, because it was so important to be flexible, like the importance of having a model that was extremely adaptable and flexible was something we found to be as important as the kind of notion of sustainability at that point, So I think, it is a bit of an unusual project in that it's part of the service doing something it wouldn't usually do.
Oh my goodness.
But I think let me leave it there. Those are some of my thoughts on some of the questions you guys raised. Back to
Thank
you,
you very much. Yes, thank you very much. We do have a couple of other comments. I see there is a question from Prof. Muno Dawafa. Prof, I don't know if you want to speak to your comment or question. I also see quite two questions from you, Cyril. Maybe you can also have an opportunity to speak to your questions. Prof, if you want to go?
Yes, thank you very much. Thank you, colleagues. Very refreshing. Thank you to the presenter. I think a couple of the comments I wanted to make, observations have already been made. In particular, the last comment around things that come introduced at the height of an emergency such as the COVID, and then gets people to jump on board, get to do some things that they have not done, but then they are left. I asked about, because we are talking health systems, and I think we're in search as a continent, as Africa, of what works or where can we invest? Where are the gaps? Where are things that we are doing very well? And I, for one, strongly believe in the observations I've made that the issue around the governance issues, or which links you to the leadership, is our weakest point. Money is there, people who are willing to work are there. I was asking the question then about your project, where that leadership on the VAX taxi. And I think you have already answered a part of that the VAX tax is no more. It is gone, and it is gone just as the COVID was going out. So what would you do differently to have a leadership that can, sustain some of the community initiatives and diversify? They don't have to stay with COVID, but there are a lot of other community issues that the health system ought to respond to. But I don't believe those people now are told there is nothing else to do with VAX taxi have any energy to do anything. So for me, it's a question, it's a comment in general that I think we should be thinking about the long term right at the very beginning, so that we don't get to a conclusion like the what we are seeing. I think it's good that you're talking of Tedros coming and all that, and we know that from community development issues, where big political people come, there is some background to it. They don't just show up. There would probably better things happening elsewhere, but they were not connected. So yes, he did come, he motivated, but I think we should also have built on that. So I will stop here, but my passion in health systems is really to look at what have we done in terms of building a strong leadership for sustainability. Thank you.
Great. Thank you so much, Prof. Mono. Prof. Mono is actually joining us from across the border from Zimbabwe. So we're very happy to have him with us this afternoon. Cyril, do you want to speak to your questions, and then we will go to Sarah, and then Leanne, you can respond.
Yes, thank you very much. Lenny, Brady, thank you for the presentation. I think it's exciting to hear this. Here in Ghana, I remember at some of our facilities, which are remote, very, very remote, I quite recollect that for them, they were even asking that if we can provide them with a van, something more like the VASI taxi, but they carry the vaccines in the boxes and take them to the people. Fortunately, when they go there, probably they try to educate them. We did, before the vaccination, we did what we call the vaccine communication education. So we use the radio stations, and some of our people who are at remote places, like the one I'm just citing on, what they do is that because they don't have the radio system and things, they move somewhere in the evening to those places, because it's a farming community as well. And during the day, you will not meet anybody in the house. So they also try the door-to-door thing, and they were vaccinating the people in the evening when they were supposed to be closing from work. So I really like this presentation you made. My request would be that we'll have a copy of your slide so that we can share with that team here to also understudy what went on with the VASI taxi. And also it's encouraging to see that the vaccination numbers were increasing with their efforts alongside the mainstream team. So for replication, I think it will do a good for us here to have the slide so that we can share with our colleagues who couldn't partake in this very forum or webinar. Thank you so much. I think it's a thumb up. Kudos to the Vasi Taxi team. It's great experience so shared.
Yeah. Thank you so much, Sarah. Cyril, do you want to speak, or I can just read your questions? Okay. So Leanne, I'm just going to read out Cyril's questions or comments on the chat. He says, the Vaxi taxi, though led to very good outcomes, it was not sustainable. Can it then be said to be a resilient capacity building approach? What was learned from its shortfalls to build on its sustainability? I think he has another question. Let's see. Okay, the next question he has is, how do we communicate the importance of new ideas that we think can build the resilience of the health system to policymakers to be able to influence adoption? So maybe you can take those questions, and then we move closer to wrapping up. Thanks, Dan.
Thanks, Dintle. Right, let me start, I think, with the way Prof's questions in some way are quite similar to the first part of your question, Cyril, about how if the Vaxi taxi is no longer, was it then sustainable? Or if we're then saying it wasn't sustainable, is it then could we then really call it a resilient strategy? And I think for me, and there might be other views of this, of course, but sometimes we think about sustainability in a very narrow sense. Yeah. And I think, Prof, you asked the question, where should we invest? And I think for me, where we should invest is in the people of the health system and in building these collective capacities. Because even if the Vaxi taxi is no longer, the ways in which those networks, which we would see as a cognitive, a contextual capacity, enable other initiatives, are still very strong and helping with a range of different things. I can give a few examples in a second. The same with the cognitive capacity. So these mindset shifts we saw in many people across the service have fundamentally changed how our service operates, So people that had not been able to go back to work for years are now back on the road, are excited to be there, are working with community groups. So I think that kind of cognitive capacity and mindset shift to think differently about sort of how our role in the health system is also about community building, community mobilization, I would see as how you build, I would see that as an example of sustainability beyond the vaccination efforts. Because as you said, Prof, it doesn't necessarily need to be with the Vaxi taxi, but what else is there? And there are multiple conversations now within EMS about the different areas, and a couple of projects underway, which are building on some of the networks, sometimes with the exact same teams, or sometimes just with the kind of networks that were built by other teams in particular districts. So I think for me, sustainability is a lot about nurturing the capacities and what other responses are possible for other initiatives or to other stresses moving forward. We've seen, for example, initiatives where we've had flooding in a facility that was responded to in an incredible way as a consequence of relationships built between ambulance crews, hospital staff, pharmacists during Vaxi taxi efforts, because people were already on the same WhatsApp group. They could quickly evacuate patients. They all knew each other, trusted each other. And so the way in which they could respond to a flooded facility was strengthened because of the capacities built in the vaccination efforts. So I think there's ways in which when we talk sustainability, it has a lot to do with the way in which we invest in our people in the health system and in the systems we set up, some of which are formal and informal routines or ways of thinking or networks that enable responding to other stresses. And for me, that's an example of how the benefits will be sustained, even if the Vaxi taxi as we know it will be no longer. So our rural Vaxi taxi was closed. Our metro one is actually still going to run for a few more months, but it's very different from how it once was. And I guess, for me, that doesn't mean it wasn't a resilient strategy, but I recognize there might be other ways of thinking about this. But I think the fact that we can see those capacities at play in responding to other crises or in doing things differently, such that our ambulance service is more responsive to community groups, for me is an example of why it's a transformative strategy. I think, Prof, you asked a question about leadership and governance. And I think, that question came up repeatedly. And what we sought to kind of enable in the Vaxi Taxi was a distributed form of leadership where governance was quite shared. And actually, it was a way of, for example, the Cape Winelands team that I spoke of, there were many governance mechanisms in place to ensure that no vaccines were misused. I think of all the initiatives across the province, the Vaxi Taxi had the lowest wastage rate of vaccines of anywhere, because if they had one dose left in a vial, they found someone on their way to the pharmacy to return the vials to give it to. So there were ways in which we were sort of, the ways in which our accountability to not waste vaccines was much higher than fixed facilities, for example. And there were mechanisms in place to make sure that, no vaccines were misused, but there were forms of social accountability where ambulance crews were accountable to the neighborhoods in which they worked and the people who wanted vaccination events in their areas, that I think led to much greater governance mechanisms, because we had more sort of horizontal or social accountability sort of at play as a consequence. As contrasted to where maybe you were given an instruction in a more hierarchical way. So I think it was quite interesting. It's definitely, we don't have enough time today, but it's definitely something to dive into much more. But for sure, one of the lessons was about how, when you share power in this way and you allow for social accountability, you get a form of governance that is actually much more robust than what we saw in other vaccination efforts. But as I said, this analysis is ongoing. So along with my PhD supervisors, Lucy Gilson and Asha George, we are diving deep into this data, and I'm sort of connecting with the colleagues who are part of it to get to the bottom of some of these questions you're raising. So I don't have answers for everything, but I think that's where my head is at the moment. And yeah, we definitely are planning to share this more widely once we have finished our analysis and put it out in paper form. So yeah, let me leave it there, Dintle. I think I spoke to most points, maybe not all, but I see we only have 3 minutes left, so I'll pause for now.
Leanne, thank you so much. And I want to pass my gratitude to all the colleagues that attended with us this afternoon. 2 key things that I also want to mention, especially also drawing from your presentation this afternoon, that also connects to some of the webinars that we have done in the past. The first thing that Leanne mentioned when she was introducing herself to us was describing herself as an embedded researcher. Some of you that have been following our series, we've had a session where we were talking about embedded research and why that matters, especially for many of you here that are either students, many of you that are either practitioners, and some of you that actually perhaps would identify themselves as researchers. So what you begin to immediately see, and what I'm hoping people are also taking out over the many great lessons that we are able to draw from the presentation that Leanne shared in regards to what they did with service delivery, is what embeddedness is able to accord you. So the first thing that we are able to see here is there was an element of service delivery during a crisis. And within that, because you also have a service provider who also is wearing multiple hats at any given point in time, was able to allow this particular service to, sort of make the EMS to become a learning organization. So they deliver services, but at the same time, they are also looking at the multiple and various mechanisms that allow them to deliver service in many different ways that they were able to. So even as we are raising questions that, you know, speaks to the traditional way of how we strengthen the health systems, issues of sustainability, and so on, what I'm hoping that people are also begin to realize and to begin to learn about is this ability for us as service providers or practitioners to recognize that even when we are delivering services, we need to look at our way of doing things and move our organizations to learning organizations, to be able to recognize what make things work well and what might not make things to work so very well. So we begin to recognize that through the everyday activities that we do, as we try to respond to some of the challenges that we encounter within the health system. Leanne talked about this notion of learning and unlearning certain things that we have often have, our preconceived ideas about how things ought to work and where we want to move things towards. So I just want us to wrap our webinar this afternoon to say, beyond the many learnings that we are able to draw from the Vaccitex initiative that we have heard about in South Africa and how that became an adaptive response of the health system during the COVID pandemic, is also an opportunity to many of you, again, that might be students in our midst that are here, to recognize, you know, the many different lenses through which we learn to build capacity within the health system, how we go about doing that, and how we also position ourselves as actors in the health system to be able to allow the learning to go back into the system to strengthen it. So I just want us to end here and to again reiterate the fact that maybe perhaps our next webinar will, you know, use this again as a springboard to continue the conversation, especially around this whole concept of resilience, to say, having learned what we just went through as health systems across the continent and moving forward, I know many of us, perhaps in our various health systems, everybody is talking and asking the questions, what are the lessons that we can take from COVID-19? How do we prepare ourselves from the next public health emergency or public health threat, be it from climate change or be it another pandemic? Are we preparing ourselves very well? Are we building the muscle in a way that is able to respond not just to acute shocks that we can experience from time to time, but how do we especially deal with the chronic shocks that our health systems continue to face today? So hopefully those are some of the things that we will take into consideration even as we think of the next webinar. I don't know if I am closing anybody out with a burning question.